This is AMP Live Studio. I am your host. I teach AMP as a registered nurse and anatomy and physiology instructor for advanced healthcare professionals. All right, let's jump right in. Picture this. You're in the emergency department and you've got a tough diagnostic puzzle on your hands. Your patient is Axel. He's a 27-year-old professional violinist, and he comes in with a sudden high fever, severe body chills, and that deep, awful muscle ache we call myalgia. Now, his history is significant. He's been vaping for about 5 years, and there's a family history of lung cancer. So the big question for everyone on the team is this a classic case of the flu, or are we dealing with COVID-19? We're going to use Axel's case to really dig into the core differences between these two viruses. Okay, so before we can really get into what goes wrong, we have to talk about what's supposed to go right. Think of our respiratory tract as this incredibly well-defended battlefield. And that first line of defense, our primary barrier against anything we breathe in, is the respiratory epithelium. And this defense system, it's not just a passive wall, it's an active, multi-layered operation. First, you've got the mucociliary escalator. It's like a biological conveyor belt, right? Mucus traps all the gunk, and these tiny cilia are constantly sweeping it up and out. Then, if something gets past that, deeper down in the alveoli, you have resident alveolar macrophages. They're like the security guards on patrol, gobbling up any invaders they find. And finally, the epithelial cells themselves are locked together with tight junctions, creating a really solid physical barrier that a virus has to somehow break through. All right, so let's zoom in. We're going from Axel's big picture symptoms all the way down to the molecular level. How on earth do these viruses get past all those defenses we just talked about? Well, the answer comes down to something we can think of as a lock and key. The virus has the key, and our own cells have the lock. And here's the thing, their keys are totally different. The flu virus uses a surface protein called hemagglutinin to bind to sialic acid receptors. Now, these receptors are packed onto our respiratory epithelial cells, which is why the flu usually stays pretty localized to the airways. But SARS-CoV-2, it's a different story. It uses that famous spike protein as its key, and its lock is the ACE2 receptor. Here's the kicker. ACE2 receptors aren't just in the lungs, they're all over the body, especially on the endothelial cells that line our blood vessels. This one small difference, which lock they pick, is the entire reason their disease patterns are so different. So why do we keep getting the flu year after year? Well, influenza is a master of disguise. It evolves through two main tricks. The first is called antigenic drift. Think of this as small, gradual tweaks to its key proteins. It's just enough of a change that our immune system doesn't fully recognize it, which is why we get seasonal flu and need a new vaccine every year. But then there's antigenic shift. This is the big one, a major, sudden change. This happens when different influenza strains, maybe from a bird and a human, swap huge chunks of their genetic code. The result is a brand new virus that our immune systems have never seen before. That's how you get a pandemic. This table does a fantastic job of laying out these key differences side by side. So let's quickly run through it. Etiology, yep, they're both RNA viruses, just from different families. Cellular entry, we just covered that. Flu hits sialic acid. COVID hits ACE2. But look at this. The differences continue even after they get inside the cell. The replication site for influenza is all the way in the host cell's nucleus. COVID-19, on the other hand, just replicates in the cytoplasm. And all of this leads to the bottom line, the primary damage. For the flu, it's mostly epithelial cells in the respiratory tract. For COVID-19, it's that widespread systemic damage to the endothelium. Okay, so now that we have this molecular backstory, let's head back to our patient, Axel. It's time to connect the dots and see why these two infections look so different at the bedside. Every single symptom he's feeling is a direct result of the cellular level battle we've just been talking about. So let's tackle the first big question. Think about classic flu. Why does it hit you like a truck? What's behind that famously abrupt and severe onset? That sudden onset, where people can tell you the exact hour they started feeling sick, it's all because of how efficient the flu virus is. It just rips through and destroys those respiratory epithelial cells really fast and on a massive scale. All that cell death sounds the alarm, triggering this huge, rapid flood of inflammatory cytokines into the blood. It's that cytokine storm that's causing the high fever and those terrible, deep body aches, the myalgia that Axel is dealing with. Okay, now let's flip the coin and look at COVID-19. Why is its presentation so different? Why the slower, more gradual onset? And that really unique set of systemic symptoms? Well, with COVID-19, the onset is usually much more sneaky. It kind of creeps up on you over several days. This slower start might actually give the virus more time to spread around the body before you feel really sick. And those signature symptoms? They all trace back to that ACE2 receptor. The loss of smell and taste is linked to the virus hitting cells that support our olfactory neurons. And the really critical part, the systemic vascular problems, like those tiny blood clots, is a direct consequence of the virus latching onto ACE2 receptors all over the endothelial lining of our blood vessels. Now, the story doesn't always end when the fever breaks. For a lot of people, the impact of these viruses can linger long after the acute infection is over. We're seeing more and more evidence of these significant post-acute syndromes, where the infection leaves an echo that can last for months or even years. You know, for the longest time, we thought of the flu as something you get, you feel terrible for a week, and then you get over it. But massive new research is really starting to challenge that idea. This quote from the FinGen study is telling us we need to start thinking about influenza as a systemic event, something that can actually kickstart a chronic disease process. This is leading to the whole concept of a long flu. Of course, the idea of a post-viral syndrome is something we're all much more familiar with now because of long COVID, and the scale of it is just huge. The CDC says about 7.5% of adults in the US who've had COVID end up developing long COVID. Just pause and think about that number. That's millions of people who are still suffering from persistent symptoms. It's an absolutely massive public health challenge. And when you actually compare the long-term problems, you start to see this really unsettling parallel. This chart shows it pretty clearly. Both infections can lead to long-lasting multi-system issues. After the flu, we see a definite lasting risk for serious cardiovascular events, like blood clots and heart attacks, and also for neurological problems, from migraines to neurodegenerative diseases. What's so striking is that this risk profile looks incredibly similar to what we see with long COVID. It really drives home the point that long flu is a real and serious clinical issue. So, let's get back to Axel in the ER. How do we get him from, we're not sure what this is, to a solid definitive plan? Well, it's a step-by-step process, moving logically from our initial suspicion to a very specific therapy. First, it all starts with clinical suspicion, right? Based on his story and how he presents. Step 2, and this is crucial, is getting confirmation with molecular testing, usually a PCR test, to know exactly which virus we're fighting. Once we have that diagnosis, we move to step 3, risk assessment. We look at everything to figure out how likely he is to get really sick. And that assessment then leads us to the final step, starting a targeted antiviral medication. And with these, getting started early is absolutely key. And our best treatments are designed to be really specific. They're built to sabotage a particular step in the virus's life cycle. For the flu, one of our go-to drugs is oseltamivir, a neuraminidase inhibitor. Neuraminidase is basically the pair of scissors the virus uses to snip itself free from the cell it just hijacked. So if we inhibit it, we essentially trap all the new virus copies, and they can't spread. For COVID-19, a key tool is protease inhibitors. These drugs gum up the viral assembly line, so the virus can't build new copies of itself. So when you pull it all together, it's crystal clear these are not just respiratory diseases. The respiratory system, sure, that's the front door and where the initial damage happens. But the cardiovascular system takes a huge hit with that increased risk of heart attacks and clots, all thanks to endothelial damage. The nervous system gets involved too, with acute symptoms like the loss of smell and those scary long-term risks. And of course, the muscular system feels the heat from that cytokine release, which is what causes the crushing myalgia that brought Axel to the ER in the first place. All right, let's wrap this up by tying all these pieces together, from the normal physiology to the pathology, into one clear clinical picture. If there's one thing to take away from all this, it's that the molecular mechanism is everything. That very first handshake between the virus and the host cell, whether it's the flu's hemagglutinin grabbing onto sialic acid or COVID's spike protein locking onto ACE2, that one event sets the stage for everything else. It decides whether the primary damage is epithelial or endothelial, and that in turn explains exactly why we see such different symptoms and why our treatments are designed the way they are. And that leaves us with a really important question for our clinical practice. We're now in a world where these viruses are circulating at the same time. So how can our deep understanding of these mechanisms, especially with post-acute syndromes like long flu becoming clear, reshape how we monitor our patients and approach preventative care long after the initial infection is gone? This video is for educational purposes only and is not intended as medical advice, diagnosis, or a substitute for professional healthcare decisions. Stay patho-curious and see you next episode.